its people. So I want to thank you again for inviting me to be here with you today. So here's the problem, and that is that in spite of the progress that we've made over the last couple decades, the mortality for heart failure continues to remain high, and it's simply not improving. This is data from the British National Health Service looking at short-term, mid-term, and long-term survival in heart failure, and you'll see that the survival curves over the last 15 years or so have not improved. Now compare this to the other major cause of death, which is cancer, and you can see that in not only in the UK but also throughout the world, there have been significant improvements in survival from most forms of cancer, significant reductions in the mortality associated with the largest numbers of cancers, and a tremendous amount of variation in survival between the different cancer types. Now, we have in our armamentarium a number of therapies which have been proven in large-scale, prospective, randomized clinical trials to improve survival for patients suffering with chronic heart failure. ACE inhibitors, angiotensin receptor blockers, beta blockers, MRAs that we heard about, their role in hypertension just a short while ago, and also devices like CRT and also ICDs. And look at the numbers needed to treat. In many cases, you only need to treat a handful of individuals in order to save one life. And yet, here's the issue, and that is that the number of patients who are eligible for these therapies simply aren't receiving the therapies. 1/5 of patients who are eligible for angiotensin receptor blockers or ACE inhibitors don't receive them. 2/3 of patients who are eligible for MRAs don't receive them. And a big challenge for us in the United States with our African American population, 90% of patients who are eligible for this life-saving therapy don't receive it. And so this is a term that you heard Dr. Olin use a short time ago, and I'll repeat it in the context of heart failure, and that is that we continue to see therapeutic inertia, which is a failure to initiate guideline-directed therapy, as well as a failure to escalate the doses to those that were used in the clinical trials. So we need to do a number of steps in order to close the gaps in terms of our performance. We certainly need to develop new therapeutic targets in order to continue to lower the mortality associated with heart failure and reduced ejection fraction, but also heart failure with a preserved ejection fraction, which accounts for almost 50% of the cases of chronic heart failure. We also are now beginning to recognize the intricate link between type 2 diabetes and chronic heart failure. And also I'll wrap up by talking about a new therapeutic target, and that is functional or secondary mitral regurgitation. So many of our therapies for heart failure and reduced ejection fraction are based upon this, which is the neurohormonal hypothesis. And this hypothesis holds that following some injury to the myocardium, whether it's a heart attack or myocarditis, there is a drop in left ventricular performance. And in response to that drop in left ventricular performance, the body activates certain compensatory neurohormonal systems, such as the renin-angiotensin-aldosterone system, the sympathetic nervous system, and others. And in response to this, these compensatory systems help to preserve circulating volume and help to preserve organ perfusion in the short term. But over the long term, they are actually deleterious. They propel the symptoms of heart failure, and they also drive its mortality. Well, we now need to go beyond the neurohormonal hypothesis, and we have to look at other models that can explain this progression of heart failure, morbidity, and mortality. And there are now a number of agents which are being investigated in phase 2 and phase 3 clinical trials. Some of them I've listed here in this slide. The ones that have made it a little bit further along in terms of development are highlighted in red, such as renin inhibitors, different mineralocorticoid receptor antagonists, vasopressin antagonists, new reglins, which are an interesting compound class of molecules which are involved in tissue repair, myosin activators that I'll talk about in a minute, as well as some others such as soluble guanylate cyclase modulators. Now, one of the ones that you should be familiar with is the new drug called sacubitril valsartan, or Entresto, and this is a unique compound that takes advantage of the natriuretic peptides. This is actually two drugs in one. It consists of a drug called sacubitril. Sacubitril is an inhibitor of neprilysin, and neprilysin, as you will recall, is an enzyme that breaks down certain vasodilatory peptides such as ANP and BNP, but it also breaks down angiotensin II. And because it breaks down angiotensin II and we are inhibiting it, we need to provide valsartan, which is an angiotensin receptor blocker, in order to block the adverse effects of angiotensin II. Now this compound, at the time it was called LCZ696, was tested in the Paradigm heart failure trial, which was conducted 4 years ago. It was a large-scale clinical trial, enrolled over 8,000 patients with symptomatic heart failure, an ejection fraction of less than 40%, elevated biomarkers, elevated natriuretic peptide levels, or a hospitalization for heart failure. And in our general parlance in the United States, I happen to be a big baseball fan. The result of this trial was a grand slam. It reduced the combined endpoint of death or first hospitalization for worsening heart failure by 20%. It also reduced the individual endpoints of cardiovascular death and first hospitalization for worsening heart failure also by 20%. And it was proven to reduce all-cause mortality by about 16%. Now, there are different ways of looking at the impact of this trial. One of them, which is certainly of interest to our patients, is how much life can you gain by taking sacubitril valsartan. So a very nice analysis that was published in the New England Journal showing that on average, persons who are taking sacubitril valsartan can increase their survival by almost a year and a half. When one considers that the median survival for heart failure is only 5 years, this is a significant improvement in survival. Not only does it improve survival, it decreases the time or increases the time to first hospitalization. You can see that LCZ696, the effects in slowing the need for first hospitalization occur almost instantaneously. I'll just draw your attention to the fact that in the scale, these are days after randomization, not months or years. So within 30 days, you can already see a significant effect of the medication in preventing heart failure hospitalization. Not only does it reduce the first hospitalization, it also reduces subsequent hospitalizations, and we recognize that almost 30% of persons who are hospitalized with heart failure will be rehospitalized in the next 3 to 6 months, and sacubitril valsartan lowers that risk. And in fact, it does everything well. Whether we look at the primary endpoints of the Paradigm heart failure trial, the secondary or the exploratory outcomes, sacubitril valsartan improves everything. And so if we were to think then, what is the challenge with sacubitril valsartan? It's not so much what the drug does, it's the fact that we don't prescribe enough of it. In the United States, it's estimated that annually, if persons were to switch from an ACE or an ARB to sacubitril valsartan, almost 28,000 lives could be saved. And yet, what's happening is that it has been very, very slow to be prescribed by cardiologists and internists in the United States. You can see that following the publication of the ACC-AHA guideline, which gave sacubitril valsartan a Class 1 recommendation for treatment of chronic heart failure, you can see that although that publication was there and although the volume of prescriptions increased for sacubitril valsartan, I'll just draw your attention to the value. Only 2.5% of persons who are eligible for this medication are receiving sacubitril valsartan. Now, why is that? And I think Dr. Olin alluded to it. It's this therapeutic inertia. If we look at a nice analysis that Scott Solomon did of the Paradigm heart failure trial, he looked at the time from hospitalization to enrollment in the Paradigm heart failure trial. Those patients who are more proximal to a heart failure hospitalization are considered to be sicker. And if you look at those folks who were enrolled within 3 months of a hospitalization, you can see that over the course of the trial, almost 30% of these individuals reached the primary endpoint, and almost 20% died over a median follow-up of just 2.5 years. Well, let's look at the quote-unquote healthiest population, and those are folks who had no previous heart failure hospitalization. In this group that one would consider to be stable, 20%, 1 out of 5, had a primary event over the course of the trial, and 17% died over the course of 2.5 years. These are almost the same values for patients who are considered to be sicker with a more proximal heart failure hospitalization. So I would argue that a person who is sitting in front of you, who is on a stable dose of an ACE inhibitor and a stable dose of a beta blocker, although they may report good symptoms of exercise tolerance and may not look congested, they are still at very high risk of experiencing an event. Now, Adam DeVore at Duke University looked at the persons who are more likely to receive sacubitril/valsartan, and what you can see is they tend to be younger, they are less likely to have chronic kidney disease, they have a lower ejection fraction, and they're more likely to have received a cardiac resynchronization device. So I think what really drives this inertia about prescribing sacubitril/valsartan or switching stable patients off of an ACE inhibitor has to do with the perception of potential side effects of the medication. And it is true that in general there were more patients who were symptomatic with a low blood pressure and those patients who were receiving sacubitril/valsartan, but as I'll show you in a minute, very few of them actually experienced an adverse event. There's been concern that having a lower blood pressure with the medication may lead to worsening renal function. It's actually not true. Patients treated with sacubitril/valsartan had better levels of renal function than those patients who remained on enalapril. And other nuisance side effects such as cough were less common with sacubitril/valsartan than with enalapril, and the rates of angioedema were extremely low in both groups. So this is a look at those individuals who experienced low blood pressure following randomization, and you can see that for the majority of patients that this did not result in the need to discontinue the medication, and the rates were the same whether you received enalapril or study drug. And if you look, the survival benefit that was present for the general population who received sacubitril/valsartan remained even in those persons who became hypotensive after experiencing on sacubitril/valsartan. As I mentioned before, sacubitril/valsartan has a better effect in those patients who have chronic kidney disease. If you look at the two solid lines in blue are those folks who had no chronic kidney disease and received study medicine. The ones who received enalapril and did not have chronic kidney disease are in a black solid line. And it's clearly better not to have chronic kidney disease than to have chronic kidney disease. But nonetheless, you can see that those individuals who received sacubitril/valsartan had a benefit compared to their counterparts, regardless of the presence or absence of chronic kidney disease. And in those patients with diabetes, you can also see that those persons who received sacubitril/valsartan, whether they were diabetic or non-diabetic, did better with sacubitril/valsartan than with enalapril. So why do these medications, such as sacubitril/valsartan, preserve renal function? Well, it's a very busy slide. I'll just draw your attention to the upper left-hand panel where you can see renal blood flow plotted against glomerular filtration rate. And in green is highlighted those individuals who have heart failure. In the first scenario, which is A, these are untreated patients who have a drop in renal blood flow because of low cardiac output and a drop in the glomerular filtration rate. If you add an ACE inhibitor to them, you will increase renal blood flow and you will also improve GFR slightly. But by adding a natriuretic peptide or by adding sacubitril/valsartan, what you see is that there is a significant increase in renal blood flow and a also significant increase in glomerular filtration, which ultimately is more beneficial for the kidney. So why is it that sacubitril/valsartan is not widely prescribed? And it has to do with this slide, and that is that the medication is expensive. Whether you look at the amount of out-of-pocket expense that patients pay for in the United States, which is in the top panel, or the amount that insurers pay, which is in the bottom panel, you can see that compared to the other forms of guideline-directed medical therapy, this is an expensive medication. So we need to develop other medications that also can work in chronic heart failure. This is an interesting molecule, omecamtiv mecarbil, which is a direct cardiac myosin activator. And what it does is it changes the allosteric formation of the myosin head, increasing the force of contractility without increasing myocardial oxygen demand. This was tested in the Cosmic Heart Failure trial. This was a phase 2 trial of about 450 patients who received either placebo or varying doses of omecamtiv mecarbil. And you can see that in those individuals who received the study medication, either a low dose in blue or a escalating dose in red, that there were significant improvements in cardiac function, reductions in ventricular volumes, as well as reductions in heart rate and natriuretic peptide levels. This is being studied now in a prospective phase 3 large multi-center study enrolling about 8,000 patients, and I'm happy to say that at Mount Sinai, myself and my colleagues are participating in this trial. Well, I mentioned before that diastolic heart failure or heart failure with preserved ejection fraction accounts for almost 50% of cases of heart failure, and it also stands to reason that sacubitril valsartan may be helpful in this area as well. Based on its beneficial effects on kidney function and inducing a natriuresis as well as vasodilation, we might think that this can help in diastolic heart failure. Now, this is being tested in Paragon heart failure. This is also a large multi-center study targeting about 5,000 patients with chronic HFpEF randomized to sacubitril valsartan or valsartan alone, and the results of this trial should be known in the next 18 months. I want to turn just in the last couple minutes and talk about diabetes and heart failure. We know that diabetes is associated with worse outcomes in those patients who have heart failure, whether we look at cardiovascular death or hospitalization or total mortality, and that the number of the medications that we use to treat diabetes, the oral hypoglycemic agents, actually are deleterious in patients with heart failure because they lead to too much sodium retention and fluid overload. Now, there's a new class of medicine, the SGLT2 inhibitors, which are very interesting. Now, to understand these medicines, it's important to understand what happens with glucose handling by the kidney during the day. All of our glucose gets filtered at the level of the kidney, 180 grams of it a day, and all of it gets reabsorbed. And it gets reabsorbed in the proximal tubule by the SGLT2, which is a sodium glucose co-transporter, or by SGLT1, which catches the 10% or so that escapes out of the proximal tubule. Now, the way that these inhibitors work is that they block the SGLT2 receptor, and as a result of that, it induces a glycosuria and a natriuresis. Now, in response to that, there are several physiologic changes. The first is that the loss of sodium and the loss of fluid in the urine induces a volume loss, which then results in a drop in atrial natriuretic peptide secretion. As a result of that, you get renal arteriolar vasoconstriction, and that vasoconstriction actually decreases renal blood flow. Now, the other thing that happens is that the increased sodium concentration that's being delivered to the distal tubule activates the juxtaglomerular apparatus. This then leads to further constriction of the afferent arteriole, and it also leads to an inhibition of renin release. That inhibition of renin then leads to efferent arteriolar vasodilation. The net effect of this is a renal protective effect that decreases the amount of pressure, the hydrostatic pressure in the glomerulus. Now, all new oral hypoglycemic agents in the United States are mandated by the Food and Drug Administration to go through prospective testing to make sure that they are safe from a cardiovascular viewpoint. What we learned from the IMPA-REG trial was that the empagliflozin, which is an SGLT2 inhibitor, reduced the primary endpoint of myocardial infarction, stroke, and cardiovascular death. It also decreased death from any cause, death from cardiovascular causes, as well as hospitalization for heart failure. Now, everything I told you about empagliflozin before doesn't explain its cardiac benefits. And one of the reasons why we think it's beneficial is because of that natriuresis and a reduction in extracellular volume. But I think it's more complicated than that. We think that what these medicines do, what these class of medicines do, is they actually have specific metabolic effects. They change from glycolysis to free fatty acid utilization by the myocardium. As a result of that, we begin to burn off epicardial fat. We now know that epicardial fat is biologically active. It reduces it secretes a number of pro-inflammatory cytokines that indirectly lead to an increase in myocardial fibrosis and myocardial stiffening. By removing these inflammatory biomarkers, we can actually improve or prevent the development of diastolic heart failure. Well, let me just wrap up in 1 minute and talk about a new therapeutic target, which is functional mitral regurgitation, clearly associated with poor outcomes in patients with heart failure. The open question is, can we treat a ventricular disease at the level of the annulus? We now have the mitral clip, which has been very effective in reducing the severity of mitral regurgitation by using the same principle as an Alfieri stitch. This was first tested in the MITRA-FR trial, which was published just a couple months ago and presented at the European Society meetings, showing no difference in outcomes in those patients who received the mitral clip. However, I will draw your attention to the fact that in this trial, 50% of patients at 1 year had recurrence of at least 2+ to 4+ mitral regurgitation, which may help to explain the difference in outcome. The other thing is that if we look at the subgroup analysis, those individuals who had higher EROA, or essentially a greater degree of mitral regurgitation, seem to actually benefit from the mitral clipping shown right here in this data point. Now this becomes important because if you consider the COAP trial, which was just presented at TCT, those individuals had a much, much higher EROA, greater than 40 to get into the trial. And I'll just show you the last two slides showing that COAP proved that there was a significant reduction of all-cause heart failure hospitalizations at 24 months, as well as this, which was a very spectacular reduction in all-cause mortality over 24 months. There are a couple ongoing trials that we still have yet to hear from, including the ReShape heart failure trial, which should hopefully be published in the next year. So in conclusion, sacubitril valsartan is safe, it's effective, but it's underutilized. It may have a role in treating heart failure and preserved ejection fraction. New therapies like myosin activators do hold promise for heart failure and reduced ejection fraction. The SGLT2 inhibitors reduce cardiovascular endpoints in type 2 diabetes, and secondary mitral regurgitation is a new target for therapy. So thank you very much, and I apologize for going over.
Excellent talk. We'll take all the question and answer in the later part. You can go ahead with the second one. I would ask Dr. Rajeev Gupta to join his chair.
So switching gears, we heard earlier this morning about the ever so important role of preventive cardiology and also not only lipid lowering but also treating hypertension. Now we're going to move to the extreme end of the spectrum and talk about patients who have stage D heart failure and talk a little bit about the latest advancements in left ventricular assist device technology. So over the last 20 years, we've seen a significant evolution in ventricular assist devices, going from the first generation devices, which were large, bulky, implantable devices that only lasted about 18 months before they broke down, to the second and third generation devices, which are continuous flow pumps that are miniaturized and yet still provide anywhere between 3 and 10 liters of blood flow per minute. Now, all of these pumps are very, very simple, and they share very common design characteristics. They're essentially a tube that connects the left ventricle to the aorta, and in the middle of that tube is one motor with one moving part, either an impeller or a rotor, that generates pressure and flow. The amount of pressure and flow that is generated depends upon the loading conditions that's placed upon the device, and in that sense they are passive. They are inversely proportional to the pressure difference across the inlet and the outlet orifices, and they are directly proportional to the rotor speed, which is what we program. There are currently 3 left ventricular assist devices which are approved in the United States for treating patients with advanced heart failure. This was the first of them. This is the HeartMate 2 device. This is called an axial flow device because the blood flow is oriented along the long axis of the impeller. This is essentially an Archimedes screw. It's an Archimedes screw which is suspended on 2 contact bearings and spins around 8,000 to 10,000 revolutions per minute and can generate normal or physiologic levels of blood flow. The second device is the Heartware HVAD device, and this is a centrifugal flow pump. This has a single rotor that can spin at around 2,500 revolutions per minute. And I equate this to like a merry-go-round where it radially accelerates the blood before it propels it out the outflow graft and returns the blood to the aorta. Unlike the HeartMate 2 device, this is a device which is completely seated within the pericardium and doesn't require the creation of an intra-abdominal pocket. Slows the pump down by 200 revolutions per minute, holds it there for about 2 seconds, and then accelerates it by 400 revolutions per minute, holds it at that higher speed for about a second, then drops it back down to its baseline. And this cycle repeats every minute. And it's designed to try to wash the internal components of that rotor to prevent clots from forming. Now, this is the latest development in LVAD technology. This is the HeartMate 3 left ventricular assist system. This is also a centrifugal flow pump, but what's different about the HeartMate 3 is that it had 3 design characteristics. The first, it was designed to have very wide blood flow passages between the rotor and the wall of the housing, and that was designed to make the pump more hemocompatible so that the blood was exposed to less shear forces. It's completely frictionless. This device, this rotor, is completely suspended by stator magnets, which keeps the device fixed in its original configuration so it doesn't pitch, roll, or yaw. And lastly, it too has an intrinsic pulse that was designed to reduce stasis and prevent thrombosis. Now, all the devices are trying to find ways to become more hemocompatible. This is just looking at the amount of shear forces that blood is exposed to as it goes through the HeartMate 2 impeller, which is shown in that bright yellow and red, as opposed to the HeartMate 3, where blood is exposed to lower shear forces in that nice cool blue color. As I mentioned before, the HeartMate 3 has a pulsatility algorithm. This one cycles not every minute, but every 2 seconds, but it's essentially there to disrupt any pools or eddies from forming where blood might clot. Now, the HeartMate 3 was tested in the largest clinical trial to date of a mechanical circulatory support device called the Momentum 3 trial. We just had the publication of the long-term cohort, which consisted of almost 400 patients with advanced heart failure, randomized to receive either the HeartMate 3 or the HeartMate 2 pump. And the primary endpoint analysis based on intention to treat was survival at 2 years, free of disabling stroke, which was greater than 3 modified Rankin scale, or reoperation to replace or remove a malfunctioning device. And you'll see that at 24 months, there was a significant 64% reduction in that combined endpoint associated with the use of the HeartMate 3 device. And if we look at various subgroup analyses, whether we look at different age, gender, race, the intended use, or Intermax profile, all of the patients who received the HeartMate 3 did better than with the HeartMate 2. But not only did this pump improve those endpoints surrounding survival, it also improved functional status and quality of life with significant improvements, early and sustained improvements in 6-minute walk test, as well as measures of health-related quality of life as measured by the Euroqual 5D score. Now, which pump is better? We have 3 pumps that are out there, the HeartMate 2, the HeartMate 3, and the Heartwear HVAD. Well, the truth is that there are only a few comparative efficacy trials. The first one was the HeartMate 2 DT trial, which compared the old generation pump to the new continuous flow pumps, and the new continuous flow pumps were clearly superior. The Advance and Endurance trials compared the Heartwear HVAD to the HeartMate 2, and if we look at the primary survival outcome, there was no difference, that the HVAD was non-inferior to the HeartMate 2 device. And then we move into the Momentum 3 trial, and you can also see that there was no difference in overall survival between those patients who received the HeartMate 2 or the HeartMate 3. So where do the differences lie? And it lies here in the amount of adverse events which are experienced by patients. Although the 1-year survival for patients receiving a continuous flow LVAD in the current era is around 80%, if we look at survival at 1 year free of a major event, stroke, bleeding, arrhythmia, infection, only 30% of patients are alive at 1 year without having experienced one of those major events. So let's look at 3 of them. Bleeding. Patients who receive a continuous flow VAD develop something called acquired von Willebrand disease. It's a syndrome that's very, very similar to Heide syndrome that we see in critical aortic stenosis, where there is a breakdown of the large multimeric forms of von Willebrand factor. Because these multimers break down, they're not able to clot blood at the site of endothelial injury. Second major complication is pump thrombosis. This is an example of a thrombus that formed on one of those contact bearings in the HeartMate 2 device. And the third, which is certainly feared by patients and providers alike, is LVAD-related stroke. And these come in 2 varieties. We see ischemic or embolic strokes. We also see hemorrhagic strokes. In general, the ischemic strokes are more common. but the bleeds are much more likely to be fatal. And so what we are left with now is this complex weave of hemocompatibility, where there are patient-related factors, pump-related factors that lead to this difficult situation of both bleeding and thrombosis. So let's look at some of the new technologies and how they impact these adverse events. The first is with the Momentum 3 trial, where the Momentum 3 trial proved that the HeartMate 3 device essentially eliminated the side effect of pump thrombosis. It also significantly reduced the incidence of stroke. And we think that those design features that I walked you through before are what are directly making this pump more hemocompatible and also reducing the adverse events. As I mentioned before, we do not see pump thrombosis, although there are some cases of clots that got sucked into the device. There have not been any cases of pump thrombosis in the HeartMate 3 clinical trial. And if we look at the direct comparison between the Heartwear HVAD and the HeartMate 2 device, you can see that there were some differences between these pumps, particularly device exchange was more common in the HeartMate 2 device compared to the Heartwear HVAD. However, the incidence of stroke was much higher in those individuals who received the Heartwear HVAD as compared to the HeartMate 2 device. And in fact, the Heartwear HVAD was found to be inferior to the HeartMate 2 for the adverse event of stroke. However, if we look a little bit more deeply in the Endurance supplemental trial, this was a supplemental trial where investigators were forced to treat blood pressure to lower targets, lowering the mean arterial pressure to a pressure less than 85 millimeters of mercury, and also providing adequate dual antiplatelet therapy and INR between 2 to 3, you can see that the incidence of hemorrhagic stroke was cut in half from about 10% down to 5%, which is a significant advance. Well, some other advancements in device technology have to do with the way that we treat patients. In our center, we believe it's very important to address mitral regurgitation at the time that a pump is implanted. This is an example of the work of my surgical colleague, Dr. Anyanwu, who will, through the apical window, will repair the mitral valve with an Alfieri stitch. And I'll just draw your attention to the lower right-hand panel, and you can see where the valve is stitched together, and here are the two separate orifices as a result of that Alfieri stitch. Well, do these procedures work? This is data from Intermax looking at all comers who are highlighted there in blue who did not receive a mitral valve procedure at the time that the LVAD was implanted, as compared to those in red where the mitral valve repair was performed, and there does not appear to be a significant improvement in survival. However, valve. So they looked at their own single-center experience of almost 300 patients, looking at those who at the end of the VAD operation were left without any regurgitant lesions versus those who still had residual valve regurgitation. About 200 did not have any regurgitation, and about 66 did. And there were, in fact, significant differences in survival over the next 3 years, showing that those patients where there was no residual regurgitation actually had a survival versus those who continued to have a regurgitant mitral valve. So let me just wrap up by asking a couple questions, and that is lifetime LVAD therapy. Can we afford it? So these pumps are very expensive. The pumps in the United States cost about $125,000. That's just for the pump and the batteries and the controller. If we add in the OR cost, the implant cost, as well as the costs associated with frequent rehospitalization, this becomes a very expensive therapy. If we look at the incremental cost-effectiveness ratio, it's about $121,000 per quality-adjusted life year. Now, this compares to about $50,000 for 1 year of hemodialysis, which is considered the benchmark in the United States for cost-effectiveness. Well, one scenario asks the question, if we could reduce outpatient hospitalizations by about 50%, or if we could reduce the implant cost by about 50%, and limit readmissions to only 1 per patient per year, you now see that the incremental cost-effectiveness ratio goes down to about $86,000, which is still expensive, but it's certainly closer to the $50,000 per quality-adjusted life year, which would be considered cost-effective. Well, one of the ways that we may be able to achieve this is by switching our implants to the HeartMate 3 device. This is economic analysis that Dr. Mehra presented on behalf of the HeartMate 3 investigators, showing that because this pump is more biocompatible, because the hospitalizations and rehospitalization rates went down, we were able to save a significant amount of money, and we would make the argument that the HeartMate 3 device is more cost-effective than the other two continuous flow pumps. So what we are left with now is a interesting phenomenon, and that is that these pumps are now beginning to achieve one-year survival rates of 85 to 90%, which is exactly the same one-year survival rate for patients who are receiving a heart transplant. And I think that with continued incremental improvements in pump technology and a focus on achieving hemocompatibility, we should be able to rival that of heart transplantation for all comers. So in conclusion, left ventricular assist device implants are rapidly increasing for not only for destination therapy, but also bridge to transplant. LVADs improve survival and health-related quality of life in spite of a heavy adverse event burden. Advances in device technology, hemocompatibility, surgical, medical management are transforming outcomes for our patients, and cost effectiveness will be achieved by reducing hospitalization and the adverse event burden. So thank you again for your attention.
It's an excellent overview, excellent overview of novel therapies for the treatment of heart failure, ARNI, as well as LVAD technology. Now we move ahead for the next talk, and subsequently we'll be having small quiz and then Q&A session. So we'd like to invite Dr. Jagat Narula for the most interesting talk of the day, that is statin intolerance and the role of PCSK9 inhibitor. Over to Dr. Jagat Narula.
Thank you, Sanjeev ji. And so now, optimizing cholesterol-lowering therapy in patients who report statin adverse events. So the few things that I would like to discuss are the causes and consequences of statin down titration and discontinuation, evaluation and management of statin muscle complaints, and role of genetics in prediction of statin-associated muscle symptoms and optimization of the statin use. So as we were discussing, and as Sanjeev ji had asked that question, just to show you that the hospitalization for the acute coronary syndrome, and this is the data that comes from the Medicare beneficiaries of less than 75 years in United States, so approximately 55,000+ patients here, you will see that pre-hospitalization in these people, at least 85% of them are not on adequate doses of statins or on no statins at all. So about 30% on no statins and about 55% of people who are on the low and moderate intensity statins. On the other hand, there are only about 15% of the people who are receiving the guideline recommended therapy. Then you will see that after the acute coronary syndrome and they have had their PCI, there approximately 10% increase in the people who receive the evidence-based guideline therapy, and so approximately 25% of them have the high-intensity statins, and 75% of them still continue to have the low or no therapy. And then you will see that in the next 1 year also, only about 10% more will receive the high-intensity statins post-hospitalization. So essentially telling that not more than 25% of the people are receiving the right kind of a therapy. The same database here from 2007 to 2013 here, you'll see that the high adherence to statins, it was found in 55,000 people, and that was compared to the people who either switched, down titrated, or discontinued the use of statins here, approximately 2,000 subjects, so it's 3.5% of them, and there are various composition of these that who are the people who changed it, switched it, who dropped it, or who down titrated the dose. And you will see that in these people who down titrated or who discontinued the use of the statins, there was a 50% increased risk for a recurrent myocardial infarction in them, and 51% increase in total cardiovascular mortality in these people. So what is statin intolerance? So the statin intolerance is when the patient is unable to continue to use statin, either because of the development of side effect or because of the evidence on a blood test that of certain markers which is sufficiently abnormal to cause concern. The second thing, that the true incidence of the statin intolerance is questioned, and the rates are conflicting because there is no standard muscle-related symptoms that you can evaluate. Then the statin-associated muscle symptoms account for 90% of the statin intolerance. And diagnosis of the statin intolerance is primarily based on the subjective patient complaints rather than any objective measurement. And statin intolerance can be either complete when you are unable to tolerate any statin at any dose, or partial when there is an ability to tolerate low or intermediate doses, or intermittent doses of statins. So the definition of the statin intolerance has been the statin down titration or discontinuation with initiation of ezetimibe, rhabdomyolysis with the statin down titration or discontinuation, other adverse events related to the hyperlipidemic agents, hypolipidemic agents associated with statin down titration, and switching for more than 3 types of statins. So this discontinuation is defined as no supply of statins for the last 90 days in a year following the statin initiation. So there are approximately 20 million people who are being treated with statins. 10 to 20% are unable to tolerate either any statin or higher doses of statins which are necessary to achieve the LDL goals. The intolerance often leads to discontinuation, down titration, and low adherence, and failure to achieve the treatment target, whether it is the dose or level, in patients with statin intolerance limitation of it limits the atherosclerotic cardiovascular disease risk reduction. Then, alternative to therapy, statin therapy is ezetimibe, which only reduces the lipids by about 18% and is unlikely to achieve the targets. So which are the people who are more likely to have the statin intolerance? And there are females, African Americans, Hispanics or Asians, and in Asians, I will also include the Indians because the reported incidence is higher here as well. The history of coronary artery disease, polypharmacy, and initiating statins at a high intensity itself. Now, before I go further, I would also like to add here a little bit of a plug about the nocebo effect. Not the placebo effect, but nocebo effect. And that was very elegantly shown by the ASCOT trial of the hypertension. In that, there was a lipid-lowering arm where the atorvastatin of 10 milligram was given with a matching placebo, and there was 5 years follow-up. There was a blinded phase, which was for 3 years, and then there was an unblinded phase, which was for 2 years. And whether you gave atorvastatin or you gave the matching placebo, there was no difference in the muscle-associated symptoms in them. But when they went into the unblinded phase, there was 26% higher muscle symptoms in the patients who were told to have the statins, suggesting thereby that this was more likely an effect which is created by the media hype about the side effects of these statins, and they called it a nocebo effect rather than a placebo effect here. So what are the types or the statin-associated muscle symptoms here? So it can happen from myalgia, myopathy, myositis, myonecrosis, and myonecrosis myoglobinuria. And as you can see here, this is recommended by the National Lipid Association Task Force, that the myalgia is when there is a muscle discomfort, myopathy is when there is a weakness, myositis is when there is an inflammation, and here you would require the biopsy. Then myonecrosis will be when there is a significant CK elevation. And if it is more than 3-fold, it is called mild. More than 10-fold is moderate, and more than 50-fold is the severe myonecrosis. And when it is associated with, how do you identify these patients? So essentially, there is the assessment scale which has been given, which is called the Clinical Scoring Index, or the CSI, for the diagnosis of the statin-associated muscle symptoms. And the most important thing here is the regional distribution, normally the proximal muscles, for example, the pelvic muscles or thigh muscles, and then the pattern, because pattern has to be symmetric. Normally, the statin-associated muscle symptoms would not happen unilaterally. They would happen because it's a generalized effect. It will be a symmetrical distribution. Then the temporal pattern that, say, within the first 4 weeks of starting the statins, more likely to be the SAMs. And then if you do the D-challenge, if you withdraw the drug, within the 2 weeks, if they improve, then it is more likely to be the SAMs. And then re-challenge within the 4 weeks of re-challenge if they develop the symptoms again. So if you put in the points as shown in the CSI, you will be able to see if it is 2 to 6, it is unlikely, 7 to 8 is possible SAMs, and 9 to 11 is the probable SAM as based on these CSIs. Then the studies which have demonstrated the use of PCSK9 in the statin intolerant subjects. The first study, which was the phase 1 study, that was called the Gauss study, and it was a randomized study, small number of patients, and it was done approximately 6-7 years ago, and the level of the LDL was seen at about 12 weeks, and essentially tried 2 dosage of PCSK9. This was the first study which tried to look at the safety and tolerability of PCSK9. And the statin intolerance was defined, as you can see here, and I do not want to go into details of it, but 77% of these subjects could not tolerate at least 2 statins in these cases. 90% of them had myalgias, and about remaining 10% had either myositis or rhabdomyolysis. And here you would see in the curves here that the ezetimibe here is used as the comparator, and then you will see that there is a significant difference in the ezetimibe versus the use of PCSK9 inhibitor. And if you add the ezetimibe to the PCSK9, there is a further drop of the LDL in these cases, and the effect is very well sustained up to 12 weeks in these cases. Then the second study was the phase 2 study, phase 3 study, which was the Gauss 2 trial. And in this case, essentially a similar study design, but this was only to demonstrate the effect on the LDL. The previous one was to show the safety of the drug. Here they demonstrated essentially the same thing, that there is a significant difference in the ezetimibe arm versus the PCSK9 arm. And again, on the red bars, you clearly can see that there is at least the target levels have been achieved between 70 to 90%, whatever the baseline LDL were. And then the Gauss 3 trial, which has recently been done, was a very cute study design, as you would see in this case, that these are the subjects with the muscle symptoms which were confirmed by the statin re-challenge. So in this trial, they had to re-challenge with the statins to demonstrate the muscle symptoms. And they had a 2-stage approach, the stage A, where they compared the atorvastatin with placebo, and then stage B, then those people who actually had the muscles, the symptoms associated to the muscles, they were the one which were randomized in a 2-to-1 fashion to the PCSK9 inhibitor and ezetimibe, and the primary endpoints, co-primary endpoint was the mean % change in the LDL-C up to about 24 weeks here. And here is the study design. As you will see that this is the part A, or the phase A of the study, where the people were given atorvastatin after a 4-week of run-in period. The atorvastatin was given, or the placebo was given. And then after the 10 weeks of treatment, there was a 2-week wash-off period. And then the people who were getting atorvastatin got placebo, and those people who were getting the placebo, they got the crossover to the atorvastatin so as to identify exactly whether the symptoms were because of the atorvastatin administration. And after that, again, there was a 2-week wash-off period, and those people who had the symptoms, so that turned out to be about 100 of them. That is only about 20% of them which were proven to be the true the statin-associated muscle symptoms, they were in 2:1 fashion. They were either subjected to the PCSK9 inhibitor or to the placebo. And then the effect was seen up to the 1 year. And then these people who were on, all these people then were given the PCSK9, and it was an open label extension of the study, which was an unblinded arm of the study after that. So what did they find? Again, up to 24 weeks, you will see that the PCSK9 brings down the levels to whatever is expected significantly, at least approximately 60 milligram % decrease in the LDL levels as compared to about 18 to 20 milligram % decrease in the LDL levels. The same results were seen in the Odyssey alternative also. The design was similar, and so were the results as was seen in the Gauss 3 trial. Now, there is a significant emphasis on the genetics of the statin-associated muscle symptoms, and there are some specific studies which have been done for the candidate gene studies. There are genome-wide association studies, there are HLA-related studies, and there are multi-omic network, as earlier Dr. Rajeev Gupta was talking about the genetic risk scores or the polygenic risk scores. So here are some of the genetic studies which have been done, and as you would see here that this is the blood vessel and the statins have been given here. So the most important thing that is focused on is on the metabolism and on the pharmacokinetics of the statins. As you would see that probably the statin, whatever dose you give, it is lingering longer, or the impact is much stronger. Why? Because the one important thing which is happening, the transporter which brings the statin in, so can it dump more of a statin into the liver? So that is the gene which really looks at it, is called the SCOLB1 gene. And then those which metabolize it, if they are not able to metabolize it properly, so these are the cytochrome 450 enzyme mutations, and then those which pump it out or throw it out into the bile acids, which are the ATP binding cassette proteins, which are probably defective and they are not able to excrete it well, essentially increasing the level of statins in the body. And then there are two other major areas. One which has been found on the immune cell, and these are called the LIRB genes, and the LIRB genes are those which are basically on the immune cells which help in muscle repair, and there is a mutation of them that they are not able to repair as in the normal subjects. And lastly, a very rare situation where there has been an autoimmunity here, where the antibodies are developed against the HMG coenzyme reductase. So there is an antibody which is formed which leads to the myopathy. And then there are some others that some subjects may have myopathy, incipient myopathy, which becomes expressed when you give the statins in these cases. So first looking at those genes which actually increase the statin levels, or they affect the statin metabolism, transport, and action. And as we discussed, that the SCOLB gene is the transporter of the statins into the liver. And the most important study that has been done is the such study. In these cases, more than 12,000 people who were brought in, and myopathy there was defined as the more than tenfold increase in the CK levels, suggesting there was at least the moderate increase in the CK levels. And so approximately it occurred in 0.8% of the participants which were randomized to the simvastatin of 80 milligrams, and only in 0.3% of the people who were randomized to simvastatin of 20 milligrams. So there was a 25-fold excess of the myopathy in the people who were on the relatively higher dose in this randomized trial, and they were able to identify quite a lot of SNPs of the SCOLB1 gene that you can see here in this case. And as you can see here, that there was a distinct abnormality, or the distinct SNPs, as you can see at the top after all the Bonferroni and other corrections in this particular case. And if you look at this SNP, and this SNP has the CC genotype, it has at least a 25-fold higher likelihood of having the myopathy as compared to the TT genotype, which is less than 0.5%. Then the immune cell, and there are studies which like the GO-DART study, which actually looked at it, and it has also been seen in the prediction and the Jupiter trials also, and has been demonstrated. Then there is an HLA basis of SAMs in the autoimmune myopathy, specifically in the blacks, where there is more than 55% likely, 55 times higher likelihood of having myopathy in these groups. And then now they are looking at the multi-omic networks, where all the pathways, including the cellular stress, immune response, protein catabolism, cholesterol biosynthesis, protein prenylation, and the RAS GTPase activation, all have been included so that the personalized medicine could be used in these cases. So to summarize, the SAMS is a major contributor to the underuse of statins and to an increase in preventable morbidity and mortality in patients from whom statin treatment is indicated. The genetic basis of SAMS has been investigated intensively, and the future studies focusing on the multi-omic networks will further delineate the molecular pathways involved in SAMS and may lead to more personalized approaches to use the statins. And to conclude, 10 to 20% people are unable to tolerate statins. Intolerance leads to discontinuation, down titration, and consequently the inability to meet the LDL cholesterol targets and provide the atherosclerosis risk reduction. Identification of SAMs by valid screening methods such as the SAMS clinical index is important strategy to correctly recognize the statin intolerant population. And there is a great efficacy and high tolerability of PCSK9 that makes it a choice of non-statin therapy, promising for large group of high-risk patients with high LDL cholesterol with statin intolerance. Thank you. Well, before I end, can I give you one more thing? I just picked it up last night. Study just appeared in circulation. Not in circulation, the Journal of American Heart Association in JAHA, which is a meta-analysis of CoQ10, because people do talk about CoQ10 a lot in these cases, and CoQ10 has not been shown to be of much use. But when you do the meta-analysis, you see that it does have an impact on the symptoms here, although not much of an impact was shown on the CK levels. But this was related quite well to the amount of dose which was given. So not the ordinary 100 milligram dose that we give, approximately 300 to 400 milligram dose, which starts to showing the impact. And longer you use it, better probably it does. So CoQ10 might have a role, unlike what we have thought earlier. Thank you.
It's an extensive overview, Dr. Narula. We'll first move on to the small quiz and followed by question and answer. People might be having a number of questions for you. It was very well covered. Moving to the small quiz, you can take a chair and then we'll having question and answer session. It's not showing on the screen. Who next? This quiz is for heart failure. The first talk by the Dr. Sean Pinney about the ARNI. The question one or the case study one, you all having voting pads with you. You can choose the option 1, 2, 3, 4, and then we'll be having the scoring. So the case is 43 years old male, is a non-ischemic cardiomyopathy, DCM, and its ejection fraction is 25%. He's symptomatic with a class 2 to 3 heart failure. And the BP is just borderline, 96 by 76. And heart rate is 80, is a quite compensated, and creatinine is 1.3, potassium 4.7. And the current medications are valsartan 40 mg twice a day, along with the beta blocker, spironolactone, aldosterone antagonist, and the other few medications. So on the basis of this symptomatic scenario, class 2 to 3, borderline hemodynamics. So what would be your line of management in this? Switch to ARNI immediately and up-titrate to the maximum tolerated dose. Second option is a switch to ARNI after 24 hours. Third is a switch to ACE inhibitor, and D is a no change. So you have voting bets. You can start. So can we have scores? So switch to ARNI is 50%, 27% is 24 hours, and 13. It's a divided opinion, but majority goes in favor of option A. That is switch to ARNI immediately and up-titrate to maximum tolerated dose. Now let's see what evidence we have. Go to the next slide. This is a sub-analysis of paradigm heart failure, which Dr. Pinney discussed in detail. So across all the BP subsets, whether it's equal to more than 140 or 130, 140, or it's less than 110, we can see the reduction in the cardiovascular death and recurrent hospitalization in all the BP subsets. So even if the BP is borderline 96/70, you can safely prescribe ARNI. Moreover, because patient is symptomatic, class 2 to 3 heart failure, already on valsartan, so there is no point in waiting for 24 hours. You can immediately switch to ARNI and up-titrate to maximum tolerated dose for the maximum symptomatic as well as mortality benefit. Next. Yeah. Let's have a comment from Dr. Pinney. Yes?
So I'll just make one point. What always impresses me is I think that we want to be safe when we take care of our patients. And so I think it's appropriate to be concerned about that blood pressure of 95, 96. I personally answered A. I would switch them to sacubitril valsartan. And I mentioned the analogy between heart failure and cancer. Heart failure is a fatal disease. Median survival is 5 years. The prognosis with heart failure is usually worse than that with most cancers. And yet, if you had someone with cancer, are you going to withhold cancer chemotherapy? The answer is probably not. You're going to try it. And so I always make the argument that this is the appropriate time to go ahead and challenge the patient and see if they can tolerate the medicine. Don't assume that they can't tolerate it. Go ahead and try. But the other thing is to see if there are other things you can do with their medications to raise the blood pressure a little bit. And one of the things that we know is that in these folks who get started on sacubitril valsartan, it really enhances the effect of the loop diuretics. So I will oftentimes reduce the dose of loop diuretic in order to give them a little bit more blood pressure and also to prevent them from getting a low blood pressure as a result of losing too much fluid with diuresis. And then the other is to see if you can eliminate other medicines that might be lowering blood pressure that maybe aren't that effective. I would say that isodil hydralazine in this population with chronic heart failure, unless you're African American, I would avoid those medicines so you can get the blood pressure up and allow them to tolerate what we have right now, which is the best medicine, which is sacubitril valsartan.
Yeah, because there is apprehension in all the physician community. If the blood pressure is borderline, they don't up-titrate the dose. Otherwise, they should look at the patient's symptomatic status, hemodynamics, urine output, and creatinine and potassium values. If the potassium and creatinine they are within normal range, and urine output is adequate, and patient is symptomatically better, you can up-titrate from 50 milligram twice a day to 100 milligram twice a day, and just see all the parameters, and then up-titrate. So it's important. Yeah.
I think these symptoms, overall symptoms, whether the patient is able to tolerate it or not, and urine output, that would be very important.
Yeah. What was the beta blocker status? Beta blocker? The patient was on beta blocker. Yeah, he was on beta blocker. And this is showing how the symptomatic, the quality of life improvement with the ARNI as compared to the ACE inhibitor across all the BP subsets. Now moving to the next case quickly. The case 2 is heart failure with diabetes mellitus. Patient is 62 years old female, dilated cardiomyopathy, ejection fraction in the same range, 26%, severe diabetes, uncontrolled diabetes. She's symptomatic with the class 2 symptoms. Blood pressure is okay, 110/78. Creatinine was a little high, that is 1.6 milligram per deciliter. Potassium was 4.7. And she was on Rampil 2.5 mg twice a day, beta blocker, and mineralocorticoid receptor antagonist, and diuretics. So on the basis of this clinical subset, diabetic, you have a 26%, class 2 symptomatic, creatinine is a little high. So what would be your preferred line of management? No change, switch to ARNI with a 50 milligram twice a day, discontinue eplerenone or spironolactone, or discontinue ACE inhibitor. So out of the four, what should be your choice? Yeah. So the 56%, the 50% of the house in favor of the switch to ARNI 50 milligram twice a day. So even if the creatinine is 1.6, still they want to go to the this combination, and switching from the ramipril to the ARNI. So we need to wait for 36 hours. That's important, but it was not mentioned. Definitely the choice is to switch to the ARNI because patient is symptomatic. Although creatinine was borderline, but it's well tolerated even in the patient with diabetes and renal dysfunction. Next slide, please. This is clearly shows the different subsets of the diabetes, right from normoglycemia to pre-diabetes, new onset diabetes, and diabetes. The whole spectrum, this sacubitril valsartan combination is better than enalapril. Although with the brittle diabetes, the benefit is not that much, but definitely across all the glycemic groups, it's found to be beneficial. And the risk of cardiovascular death and hospitalization was better with the combination as compared to the enalapril alone. Next. This is with the glycemic index and the underlying renal dysfunction and hyperkalemia. So you can clearly see the yellow one is a sacubitril valsartan combination, gray is the enalapril. So renal dysfunction and hyperkalemia is comparatively less with a combination of sacubitril valsartan as compared to the enalapril alone. So it also goes in favor of, it's a very well tolerated or equally well tolerated as compared to the ACE inhibitor. So both these adverse effects were less common in the sacubitril valsartan group across all glycemic categories. So we can have a comment from Dr. Pinney.
Again, I want to point out the focus on safety and the concern that the audience had about that creatinine of 1.6. We certainly know that those individuals who have diabetes and chronic kidney disease have worse outcomes in terms of heart failure outcomes, and yet the benefit with sacubitril valsartan is clearly higher in those individuals than with enalapril or other ACE inhibitors. So I agree with the majority who wanted to switch to sacubitril valsartan.
Yeah. Can I ask a question here? So, in this particular case, would you go with only B or B plus C? It is class 2. You are giving the MRA. The benefit is not as much as it will be in class 3 and 4. So why not stop the MRA for the time being, maximize the ARNI, and then bring it in if it is needed. Otherwise, you would do well. So you will be saving the person from the kidney issues.
So Dr. Narula makes a wonderful point, which is by eliminating the MRA, at least temporarily, you can achieve or will be more likely to achieve that switch, that successful switch to sacubitril valsartan, and then reintroduce the MRA down the road. I think that would be a very safe way to proceed. I would go ahead and I'd probably continue the MRA and see how they would do, but I'll draw your attention to a really nice document that the ACC published in JAC at the end of last year, which goes through some of these challenges, which is how do we translate the clinical trials and the current evidence into practical decision-making about how to initiate and escalate therapy for heart failure patients. And this is one of those challenges that they tackle in that document surrounding chronic kidney disease and hyperkalemia. So I think if one were to continue the MRA, make sure that you follow it up with a blood draw in as few as 7 days, so a week later, to make sure that they're not developing hyperkalemia or worsening renal function. Or if you play it more conservatively and safely and temporarily stop the MRA, please make sure to re-challenge them in a few weeks to make sure that they derive the benefit from complete guideline-directed medical therapy.
So the final one-line comment from Dr. Pinney, looking into the evidence and what guidelines we have right now, say, do you advocate the patient with a heart failure to switch if they are symptomatic? All the patients should be switched to this combination? Or what specific indication you would like to recommend to all the patient community?
So the current ACC AHA guidelines state that for patients who are stable on a dose of an ACE inhibitor or on a stable dose of an angiotensin receptor blocker, that they should be switched. That's a class 1 recommendation that they should be switched to sacubitril valsartan. So in my own practice, I try to switch everyone that I can onto sacubitril valsartan and off of an ACE or an ARB.
So you switch to all the patients irrespective of symptomatic status?
Correct. And what I wanted to show you from that slide from Scott Solomon was that it's an illusion that patients who are asymptomatic and stable on an ACE inhibitor are out of harm's way. They are a very high-risk population. And what we saw in Paradigm Heart Failure in that trial population, 1 in 5 were dead in the next 2.5 years, in spite of the fact that they looked stable. So that stability it's an illusion. They're not stable.
Yeah, because of the hard endpoint reduction, cardiovascular death, and a rehospitalization, that is a burden on the exchequer if it's being significantly reduced by. So thank you very much. And then
I'd like to ask one question. What is the present class recommendation for ACE inhibitor and ARB in heart failure now?
ACE inhibitors have a class 1 recommendation for treating patients with heart failure reduced ejection fraction. For patients who are intolerant of an ACE inhibitor, you can switch to an angiotensin receptor blocker. And for those individuals who are stable on a dose of an ACE inhibitor or an ARB, they should then switch to sacubitril valsartan.
So now we can have a 5 minutes of quick Q&A session for Dr. Narula and Dr. Pinney from the audience and as well as panel. Yeah.
I have a question, Dr. Pinney. When you follow up the patient who has LV dysfunction, he is already on guideline medical treatment, and in the course of his follow-up, he develops left ventricular block, and then you have to decide whether you should switch the patient to ARNI or you have to put in CRTP or CRTD. So what will be your opinion? You will go for first device therapy or the change of the treatment?
So did you say device therapy with CRT?
Device therapy. Patient developed LBB during the course of follow-up. He developed which warrant putting of a CRT or CRTD. Ideally, because the patient has less than 30%, he is high risk for sudden death also. So would you prefer the first to go for the device intervention or the change in the therapy of the ARNI?
So I will optimize medical therapy before I put the device in, but I don't wait too long. I will wait about 3 months, and if I do not see an increase in their ejection fraction, then I will put the CRT device in. But I optimize medications first. And the reason for that is that we still see improvements in ejection fraction to levels greater than 40% in those individuals who are receiving the maximally tolerated doses of guideline-directed medical therapy.
If I could ask you on the same, just to, when the sacubitril valsartan was not available when the CRT trials were all done, right? So optimization, does it mean that I have to have the sacubitril valsartan or I can still go with the ACE or ARB?
I agree with Dr. Narula. I'm a big supporter, a big believer in cardiac resynchronization. And so for those individuals who have a left bundle branch block greater than 150 milliseconds, almost all of them will receive a CRT device in my practice, unless they are such a super responder that their ejection fraction goes up to more than 40%. But Dr. Narula, of course, makes a brilliant point, which is that if they're already on an ACE inhibitor and they're eligible for a CRT, why don't you say at that point that they're on optimal medical therapy, put the device in? I would agree with that.
So now the 3 to 4 interesting questions from the audience, and then we move ahead to the next session.
I would like to, I have questions about the ARNI. As we know that in chronic renal failure, there was already available BNP analog. And here we are also increasing ANPs, BNP and CNP. So what is the positive effect of this combination on that nesiratide which was already available.
So why are ARNIs better than nesiratide? Yes. It's a good question, and I think it's answered in clinical evidence. So although there was a lot of enthusiasm for the intravenous natriuretic peptides given in pharmacologic doses, what we saw in the ASCEND heart failure trial, at least in the acute setting, was that nesiratide did not affect any of the clinical endpoints. It did not reduce hospital readmission. It did not reduce in-hospital mortality, and it didn't even improve symptom score. So I think the pharmacologic doses of nesiratide are not helpful. On the other hand, if we look at the Paradigm heart failure trial, by enhancing not only BNP, but also ANP, adrenomedulin, and other vasodilatory peptides over a more chronic exposure, that clearly translated into a survival benefit.
Sir, we know that there are many cases of reduced ejection fraction of heart failure. So which subset of patient improved most with ARNI?
So what we know is that if you look at the forest plot from Paradigm heart failure, every population benefited equally from sacubitril valsartan. So the effect was broad, and it was not exclusive of any patient group.
Sir, will this ARNI will replace ACE in future?
I don't think it will replace ACE inhibitors. I think it will be considered superior to ACE inhibitors. I think right now ACE inhibitors have been the cornerstone of therapy for heart failure, but not everyone can tolerate an ARNI, so there will continue to be a role for ACE inhibition. There will continue to be a role for angiotensin receptor blockers. These medicines cost pennies compared to ARNIs, which are very expensive right now. And so I think, as I alluded to in my talk, until the cost of the ARNIs come down, we will continue to see widespread use of ACE inhibitors and angiotensin receptor blockers.
Sir, regarding statins, we have PCSK for prevention. Will it have you direct comparison with the statins with lifestyle and ezetimibe with PCSK in secondary prevention?
So the question is, PCSK9 in secondary prevention, is it better than statins or the same?
Well, there is no head-to-head comparison, as you know. So one would not be able to say that. All these studies which have been done, they have been done where you have added the PCSK9 inhibitors on top of the maximized dose of statin. So there are no comparative studies available as yet. The reason is that you could not take the patients off statins because the statins are already proven to be effective. So it was considered unethical to compare them. Yes, there are the studies which are available in the patients who are statin intolerant, and the magnitude of the impact in terms of the reduction in LDL has been more than the maximum doses of statins. That's all you can say about it. So outcome we don't know.
So the last question from Dr. Jitan Bakkar before we move to the next session.
Outcomes we don't know because it has only been...
It's not a question. I just wanted to comment on the question Dr. C.B. Meena asked about whether to put the patient on ARNI or do CRT. I won't mind doing both because CRT had overall advantage over and above AC inhibitor and beta blocker, same with ARNI. And these are not two surgeries that one can be done at a time. And even in MEDIT CRT, the asymptomatic population also benefited. So I would like to do both together.
No, you have to take a call first. First you will advise for this and then later on switch on the ARNI.
Why not both? That's a drug. That's just an addition of drug. In fact, that admission for CRT would help me in initializing this drug, ARNI. So I would like to do both in this case.
That's why I asked Dr. Pinney specifically that what does the optimization mean here? Yeah. Because when you had the MEDIT2 and all those studies done, at that time, the
So I'm happy
RNs were
that
not available, right?
we had one tool only and we now have two tools, so why not use together?
Yeah, the
Last
combination
question
is
to
better
Dr.
than one.
Narula. What is the current status of bempedoic acid in statin intolerant patients?
Well, the suggestions now are basically whenever you are going, if you saw the guidelines earlier also, I think the non-statin drugs when you are going for, the first is the ezetimibe and the second is PCSK9 at this point in time.
So thank you very much for the excellent session and the great interaction with the audience. Now we move on to the next session as we are running late by almost half an hour. Thank you very much. It's a moment, please. Let's stay still.